This video will cover the introduction, causative agent, transmission, clinical features, complications, diagnostic studies, management, prevention, and references related to measles. Measles is caused by the paramyxovirus and is most common in children aged 3 to 5 years. It is transmitted through respiratory droplets or direct contact, with an incubation period of 7 to 21 days. The clinical features of measles progress through two phases, the prodromal phase and the phase of eruption. The prodromal phase lasts about 4 to 5 days and includes fever, malaise, cough, coryza, and conjunctivitis. This also includes nasal discharge, sneezing, redness of the conjunctiva, and photophobia. Key features of the prodromal phase also include Koplik spots, which are diagnostic for measles and fade within a few days. Laryngeal involvement causes hoarseness and cough, and gastrointestinal involvement may cause vomiting and diarrhea. The phase of eruption is marked by a non-pruritic maculopapular rash. It starts on the head and face, spreading down the body over 2 to 3 days. The rashes deepen in color and are followed by desquamation. This image shows the typical rash associated with a measles infection. Complications of measles can include stomatitis, enteritis, pneumonia, and keratitis. Secondary bacterial infections like otitis media, bronchopneumonia, and conjunctivitis may also occur. Neurological complications include post-viral encephalitis and subacute sclerosing panencephalitis, or SSPE. Nutritional complications can manifest as dehydration and weight loss. Diagnosis is typically clinical, based on Koplik spots, the characteristic rash, and the 3 Cs. Confirmation methods include serologic testing for measles-specific IgM antibody and detection of measles RNA by RT-PCR. Measles can be mistaken for rubella, roseola, dengue, Kawasaki disease, or a drug rash. It should be considered in patients with fever and rash, returning from endemic regions. Management involves supportive care and isolation for 10 days. Key steps include bed rest in a quiet, shaded room, frequent fluid intake, and fever control with paracetamol or other agents. Further management involves broad-spectrum antibiotics, specific eye drops, oral gels, and vitamin A drops. Rehydration is crucial. Steroids should be avoided as they may compromise the immune system. Post-exposure prophylaxis is vital for non-immune individuals after exposure. This consists of the MMR vaccine within 72 hours or immunoglobulin within 6 days to lessen disease severity. Prevention focuses on the MMR vaccine against measles, mumps, and rubella. Since measles is a self-limiting disease, efforts should concentrate on preventing complications. Hospital admission depends on illness severity. Uncomplicated cases can be treated at home. Isolation precautions are necessary to prevent the spread of the disease, with airborne isolation for 4 days after the rash develops. The references used for this video include Medical Diagnosis and Management by Mohammadinam Danish and Rosen's Emergency Medicines and Clinical Concepts.